Good morning. I hope all of you are joining us today are safe and healthy, and if you are not, we wish you the best. I am Dr. Misbah, Registrar at COVID Unit at Indus Hospital and Health Network, with consultant Dr. Shamim Behram, Head of Department COVID Unit. We are pleased to welcome you virtually for ICON 2022 COVID-19 ongoing Saga session. I would like to give a brief overview of our COVID unit. Currently, it's 30 bedded, including ICU and HDU. We have catered around and managed around 26,000 patients free of cost since pandemic. The round of applause goes to all healthcare workers contributing their tremendous effort and self-devotion for working in this pandemic situation. We have tried to cover some important but neglected issues faced by COVID-19 patients, which will be covered by three repeatable speakers, followed by three oral presentations. This session is chaired by Dr. Muniba Ehsan Sayyed and co-chaired by Dr. Tahreem Ansari. Dr. Muniba Ehsan Sayyed is Assistant Professor Infectious Disease, Head of Department at SIDH and Research Center, Dow University of Health Sciences. Her notable contributions and accomplishments include establishment of COVID-19 unit at Dow University Health Sciences, Shahid Motarma Benazir Bhutto Trauma Center and SIDH Health Research Center. She is also a member of National COVID-19 Clinical Management Guidelines Working Group. Our co-chair is Dr. Tahreem Ansari. She is an assistant professor, infectious disease department at Dow University and Health Sciences Ojha campus. She is chair at AMS committee at DUHS, co-chair IC committee at DUHS, and member of PNTC committee. We thank you all of you for joining us today. It is requested to all participants to fill the feedback form in order to receive the CME certificate. Please share all questions in chat section. We will do session before proper presentations. Our first speaker, let's start this session. Our first speaker is Dr. Nashin Nasir. Dr. Nashin Nasir is an assistant professor in the section of infectious disease in the Department of Medicine at Ahan University. She is the vice chair research for Department of Medicine and the chair for Department Research Committee. Dr. Nashin Nasir has several publications to her credit and is currently involved with a number of active research projects and grants. She is a member of AKU Ethics Review Committee and the Hospital Ethics Committee. She is also a member of Hospital's Immunization Subcommittee. She is an associate editor of MMIDSP flagship journal Infectious Disease Journal. She was recognized as an international ambassador by Society of Healthcare Epidemiology of America from Pakistan in 2019, and she was the recipient of Dean's Reception Award for Research and Scholarly Contribution 2017 at Ahan University. So we shift our session over to Dr. Nosheen.
Assalamu alaikum. I'm Dr. Nashin Nasir. I'm an assistant professor and a consultant infectious diseases in Department of Medicine at the Ahan University, and I will be presenting the research highlights in COVID-19 for the year 2021. I have no conflict of interest. So, what have the global research priorities on COVID-19 been for the year 2021? Most of the research has centered around treatment, with approximately 2,914 clinical trials underway on treatment in several countries for both new and repurposed medications. The other priority has been vaccines. 34 phase 3 vaccine trials are ongoing at the moment. 19 vaccines have been authorized in limited or early use, and 9 vaccines have been approved for full use. And then variants. So all variants of concern from alpha to delta had been identified in 2020, but Omicron was the only variant of concern which was identified from multiple countries in November 2021, aside from variant of interest lambda and mu. The $1 million question that remains in COVID-19 is what works and what doesn't work for this disease. And what worked, so by the end of 2020, we knew that there was a role of steroids. The landmark recovery trial showed that dexamethasone was worked in severe and critical disease. Then there were several trials used utilizing remdesivir, and it was found that it reduced time to clinical recovery if used early in severe disease. Most of the data was from the ACT-1 trial, and it was the only antiviral approved for COVID-19 treatment in the year 2020. And then there was some conflicting data with regards to IL-6 antagonist tocilizumab for severe COVID-19. So now presenting the COVID-19 therapeutics, which are research highlights from 2021. Uh, the first and foremost was with regards to the IL-6 receptor inhibitors and data from the early RCTs, like I mentioned. There was some conflicting data. Some observational studies had reported that the outcomes were better with the use of tocilizumab, but the trial data did not show any mortality difference in patients who were treated with tocilizumab, which is an IL-6 receptor antagonist. And they did not see any improvement in other clinical parameters like use of non-invasive ventilation, intubation. And then, although there was improvement in inflammatory markers with the use of these receptor inhibitors, but there was no mortality difference which was being observed. However, the recovery trial, which was published in early 2021, in February, the results were released for tocilizumab. The recovery trial was a multi-center factorial randomized open label controlled phase 3 trial. And the results that they showed, their primary endpoint was all-cause mortality at 28 days. And the secondary endpoints were time to discharge and receipt of mechanical ventilation. 82% of the patients in this trial had received corticosteroids as part of usual care. So it was in severe to critically ill patients in whom they gave tocilizumab intravenously as an initial dose, and an optional second dose was given 12 to 24 hours later in patients who did not respond well with the initial dose. And in addition to that, they gave the usual care, and the control group was patient who was receiving the usual care. And what they found was a significant improvement in mortality in the patients who received tocilizumab in addition to usual care. And in their secondary endpoints, there was reduced receipt of mechanical ventilation in patients who were not receiving ventilation at the time of randomization. So this trial proved, as because of its massive sample size, it introduced tocilizumab as part of the standard of care in guidelines for COVID-19 across the world. These were then supplemented by other findings in other large trials. The REMAP CAP trial, which was doing enrollment in 113 sites in 6 countries. This was also a randomized, embedded, multifactorial adaptive platform trial. It was a phase 4 trial, and they used tocilizumab, sarilumab, anakinra, and compared it to patients who were receiving usual care. And they also showed similar results with better organ-free support days and better survival in patients who received the IL-6 receptor antagonist. And sort of these trials had supported the use of tocilizumab in severe to critical COVID-19, and hence this was also published in a New England Journal of Medicine in 2021 and added to the evidence in favor of IL-6 receptor antagonists. Then the other drugs that were therapeutics that came into light in 2021 were Janus kinase inhibitors, and it was shown that baricitinib was one of the agents that was investigated, and it was used in combination with remdesivir, and it showed that the in patients who had the median time to recovery was the primary endpoint, and the trial Act 2 showed that there was a modest benefit in median time to recovery. However, in patients receiving high flow oxygen or non-invasive ventilation at enrollment, the 28-day mortality difference was not significant, as well as the requirement for mechanical ventilation was also not significant. So 30% higher odds of improvement in clinical status at day 15, according to ordinal scale, with the baricitinib and remdesivir compared to remdesivir alone. with placebo. And so this was just a modest benefit. And so this came into the guidelines of NIH as part of the treatment for severe patients who were not responding to treatment with corticosteroids and who were not candidates for tocilizumab. And so in the overview of current therapies for COVID-19, also published in New England Journal of Medicine in July 2021, showed that in patients with ordinal scales beyond 5, there was role of dexamethasone. There was a modest benefit with earlier role of for Janus kinase inhibitors, and there was a role for tocilizumab in patients who had ordinal scores of more than 5, with benefit in terms of mortality. Then the most important aspect of research in COVID-19 for the year 2021 was for non-hospitalized patients. And this was basically the introduction of anti-SARS-CoV-2 monoclonal antibodies as a therapeutic agents in those patients who were not hospitalized, but who were at high risk of progression. So Blaze 1 was the first trial, which was a double-blind phase 3 randomized control trial, which investigated bamlanivimab and etesevimab in non-hospitalized patients with mild to moderate COVID-19. And what they found was a 5% absolute reduction and an 87% relative reduction in COVID-19 related hospitalizations or all-cause deaths. Another trial that investigated casirivimab plus imdivimab in non-hospitalized patients with mild to moderate COVID-19 also found a 2.2% absolute reduction and 70% relative risk reduction in COVID-19 related hospitalizations or all-cause deaths. Then Comet ICE trial, which was a double-blind randomized control trial of sotrovimab in non-hospitalized patients with mild to moderate COVID-19, also showed a 6% absolute reduction and 85% relative reduction in all-cause hospitalizations or deaths. So all these 3 trials were published in New England Journal of Medicine in 20 various time points in 2021. And all of these brought to light the role of anti-SARS-CoV-2 monoclonal antibodies in non-hospitalized patients who were at high risk of progression with COVID-19. Now, hot off the press. So there are several drugs which have recently emerged as therapeutic agents for COVID-19. The first one that I'm talking about, and I mentioned a while ago, was sotrovimab. And why I mentioned it separately is because it has role in also treatment of the variants of concern. So currently Omicron, which is affecting people globally, there may be a role of this sotrovimab, because it is the only SARS-CoV-2 neutralizing antibody which is being found to retain activity against the Omicron variant. So early treatment for COVID-19, this trial was published fairly recently in on November 18, 2021 in the New England Journal of Medicine. And what they found was that hospitalization for any cause through day 29 was less in the group that received sotrovimab compared to those that received placebo. And similarly, death was they did not observe any deaths in the patients who received this neutralizing antibody. So among high-risk patients with mild to moderate COVID-19, sotrovimab reduced the risk of disease progression, and there were no safety signals which were identified, and no serious adverse events were. Fewer serious adverse events were reported with sotrovimab. Then the next drug is molnupiravir for oral treatment, which is a nucleoside analog for treatment of COVID-19 in non-hospitalized patients. And what they found with the use of this drug was that the risk of hospitalization for any cause or death through day 29 was lower with molnupiravir compared to placebo. And this is being considered as one of the drugs that may actually be one of the most effective drugs to treat COVID-19. However, we do not now have data with regards to how effective it is in the presence of the Omicron variant. So this was published in December 16, 2021. And the findings were that early treatment with molnupiravir reduced the risk of hospitalization or death in at-risk unvaccinated adults with COVID-19. And the one that we still are waiting for the publication, and it is expected to be published in a couple of weeks, is the drug which was recently announced in Pfizer press release to be one of the major drugs in treatment of COVID-19. This is the ritonavir boosted nirmatrelvir, also basically being recognized as Paxlovid. And in the EPIC HR trial, it showed that there is a reduced risk of hospitalization or death by 88% compared to placebo in non-hospitalized adults with lab-confirmed SARS-CoV-2. What is important to know is that it is expected to be active against the Omicron variant of concern. So it has already received emergency use from the FDA. And it has however, because it is ritonavir boosted, as a protease inhibitor, there's a potential for significant drug-drug interactions. Then the research focused on COVID-19 vaccines, and there are several research highlights from 2021. And there was an explosion of information with regards to vaccines. There are more than 15,000 vaccine-related papers that mentioned COVID-19 or SARS-CoV-2 were published, out of which 11,000 or 47% were published in 2021. So a major a chunk of research in COVID-19 focused quite aptly on the use of vaccines and the efficacy of the different vaccines that were being introduced. And importantly, they centered around variants and vaccines. So how well do the vaccines perform with regards to the circulating variants? So this graph shows the different variants from alpha through mu, and it shows how vaccine effectiveness was against symptomatic infection. And we can see that almost all, so AstraZeneca was fairly effective against alpha, delta, and gamma, but less effective against beta infections. Then Pfizer effective more than almost more than 70% at least for all the different variants. Moderna slightly better performing for all the variants, and then Johnson and Johnson relatively less effective, but still effective against the two major variants, which were alpha and delta. Then hospitalization, in terms of hospitalization and death, we see that the vaccine effectiveness was high for all the four vaccines that are mentioned here. The vaccine effectiveness was better than at least 60% for all the variants that have been studied. 2021 was also considered the year of the variants. So a recent article, The Winter of Omicron, the Evolving COVID-19 Pandemic. In late November 2021, the identification of the Omicron variant of SARS was from South Africa and Botswana. So the first few cases were reported from there. And then since then, it has been detected in more than 90 countries and 46 US states. Most of the current hospitalizations and deaths are among unvaccinated individuals, but that does not mean that those who have been vaccinated have been completely spared. There are patients who have been vaccinated, who have also received boosters, and who have developed infection, but those infections have so far been of milder intensity. So future research, as the title of this session is, the COVID-19 saga continues. So there is still the search for cure. There is still the research around the threat of the newer variants. How severe are these? What are the implications? Will vaccines work against variants? That's a very important research question, and we will be seeing several studies being published during 2022 with regards to these. Then mixing and matching of COVID-19 vaccines and boosters. How do how are we faring with those? Because a lot of people have received both the mRNA vaccines and the inactivated vaccines, and how does that work? And then how many vaccine boosters will be required, and how frequently will we be getting boosters? So those are all the questions that still need answers, and they will be studied through the year through 2022, and we expect to see more data coming up in the year 2022. So with this, I would like to thank you, and I would like to thank the organizers for inviting me for this talk, and I'll be happy to take any questions in the live Q&A session. Thank you.
Thank you, Dr. Nosheen. It was a wonderful session. Thank you for enlightening us about recent advances and ongoing research on current COVID-19 pandemic. It was really helpful for all of us. Dr. Nosheen, if you are here, so we can take questions. Dr. Nosheen? So we can take questions for you. Uh, so it is requested to all participants to share all questions, and in Q&A tab, we will take the session before paper presentation. So our second speaker is Dr. Sohail Akhter. He's a professor and head of Department of Pulmonology at Indus Hospital and Health Network. He will discuss regarding chronic and palliative care of COVID-19 patients. So it's over to Dr. Sohail Akhter.
Assalamu alaikum. Just checking if you can hear me. Shall I start? Dr. Misbah, can you confirm if you can hear me?
Yes, sir, we can hear you.
Okay, thanks. This topic was given to me by Dr. Samreen because most of the focus, understandably, was on the acute management of COVID patients. And as we saw, obviously, in the mid of 2020 and onwards, that there was still a lot of problems even after the COVID saga finished. And we are still seeing it. And almost before the arrival of this Omicron variant, it was almost understood that we are just going to see this chronic cases. But then obviously everybody knows the situation has changed. So I'd like to share some research and our experience in dealing with the chronic problems and palliative care. How do I slide? Okay. So these few things will be discussed. Let's see them one by one. We have seen this slide umpteenth number of times. This tells us what goes on in the acute phase, the early viral response, and once the virus disappears from the system, it leaves behind in some patients host-inflammatory response. I don't think we need to go through it, but this highlights at least one aspect that once the acute COVID-19 finishes, in many unfortunate patients, the story doesn't end there. And there's a lot of post-acute COVID-19 problems that persist, which are conveniently subdivided into subacute ongoing COVID-19, which is up to 12 weeks of start of symptoms, and then a never-ending chronic post-COVID-19 phase with several systems involved, some with complicated problems, majority, thanks God, with minor issues, but still significant enough to warrant our attention. So conveniently, the NICE guidelines have divided the different syndromes into acute, which deals with signs and symptoms up to 4 weeks of the onset of symptoms. Then there's an ongoing symptomatic COVID, which deals with the signs symptoms starting from 4 weeks up to 12 weeks. Then there's a post COVID-19 syndrome, which is 12 weeks and beyond, which is not explained by an alternative diagnosis. Long COVID is a synonymous word that is used to mention after COVID-19 symptoms, ongoing symptomatic as well as post COVID-19 syndrome. So, what are the chronic issues and how frequent they are? Can we pick them up early, and what can we do about them? There have been several studies. This study has been very nicely conducted. This is a cohort of early patients in 2020 pandemic in China who were admitted. So means they were moderate to severe, and at 6 months and 12 months after discharge, they were interviewed for symptoms and examined, and a 6-minute walk test was done, and some laboratory test was performed. So the researchers looked at the healthcare use after discharge and how much were they able to work at 12 months. PFTs were done, chest X-ray was done at 6 months, and only those who were left with some abnormalities were repeated at 12 months. So 1276 completed both visits, and it was found that at least one sequelae symptom were found in 68% at 6 months and 49% at 12 months. So this is quite a significant proportion of patients. Story doesn't end when you go home or up to 3 months. It continues in many patients. Fatigue was the commonest symptom, which was found in 52% at 6 months and 20% at 12 months. Dyspnea was the second commonest, more than MMRC1, 26% at 6 months and 30% at 12 months. If you perform this 6-minute walk distance, you will have about 14 to 12% of patients who will have less performance, but there was no difference at 6 and 12 months. Anxiety or depression, we've seen quite a lot of patients. Obviously, the reasons we are all aware, spending some time in isolation, fear of disease, symptoms, hospitalization, etc. So 23% patients had anxiety or depression at 6 months. So a lot of residual problems. Gender-wise, women had more fatigue or muscle weakness, anxiety or depression, and diffusion impairment. And at 12 months, there were more problems with musculoskeletal issues and some anxiety or depression. Another systematic review of 45 studies dealing with about 10,000 patients looked at persistent symptoms persisting for at least 60 days after diagnosis. And they found that individuals who experienced at least one persistent symptom was the proportion was 73%. And most frequent symptoms were again the usual dyspnea, fatigue, and sleep disorders. This is a Pakistani study published about a year ago, which looked at COVID-19 sequelae after a month from discharge, and this was 150 patients were questioned, and majority up to 95% experienced at least one symptom, and the usual symptoms were the same. This looked at the ongoing versus post-COVID syndrome symptoms, and they showed that at ongoing, which ends up at 3 months, and post-COVID, which continues after 3 months, several symptoms related to neurological systems, respiratory systems, and musculoskeletal persisted for quite a long time. So we at least come to know that after discharge, even after a month of acute symptoms, there is a plethora of symptoms that the patient can expect, and it is also our duty as healthcare workers not to leave them alone, and there should be in every healthcare system a system to monitor patient, not necessarily calling them for OPD for a year or two, particularly those who do not have symptoms, but at least warning patient that they may have symptoms, and giving them a liberty to call back if they have persistent symptoms, and certainly following those who have post-COVID symptoms. And this is a simpler slide from the WHO. These are the commonest symptoms which are left in post-COVID patients for several months after discharge. It is not that only those patients who were on ventilators or who had massive lung involvement or very high blood markers were left with long COVID symptoms, but studies have shown that even mild to moderate cases who even did not require respiratory support, even those who had asymptomatic COVID 19 and children, were also found to have long COVID effects for a long period of time. Symptoms were dyspnea, fatigue, myalgia, cognitive impairment. In virtually every review that I studied for preparation of this talk, I found consistently these 4 or 5 symptoms of dyspnea, fatigue, musculoskeletal, and neurological or psychological problems. Focusing on what happens in the lungs. Dyspnea and hypoxia, of course, are the two major problems. When these patients were studied, were actually evaluated in different studies, the consistent findings were decreased diffusion capacity. If you do a spirometry, it shows considerable restriction, and radiologically, several months after discharge, there were some persistent ground glass opacities. Let's look at some of the figures. This study published last year in the Journal of the Royal Society of Medicine was a review. In a sample of 57 patients, 30 days after discharge, there was decrease in lung diffusion capacity in about half patients, diminished respiratory muscle strength in half patients, and in another study up to this was a month, and this in the second study up to 3 months after discharge, the lung function abnormalities persisted in a quarter of patients. What I would like to focus is which marker was the most significant, and it was not spirometry, which we focus on because it is easily available and it is the most frequent, most familiar with. It was a carbon monoxide transfer factor. They also showed that a high level of D dimer at presentation was significantly associated with the abnormalities in the carbon monoxide transfer factor, and thought and postulated that whether it is a potential biomarker. Of the patients with lung function abnormalities, 12 also had radiological changes. So it was the carbon monoxide transfer factor, repeating again. And what about the radiology? Radiological abnormalities in the chest CT were found in 71% of a small cohort at 3 months post discharge. And what should we do if the patients are left with radiological abnormalities? We will see in the next few slides, even up to bilateral involvement, ground glass opacities on the high resolution CT scan. One thing which I would like to emphasize is curb the tendency of doing repeated CT scan in patients who have dyspnea. I think a 6-minute walk test can be a very good sensitive marker, and only those patients whom we have excluded other conditions should be subjected to a follow-up HRCT, if at all, because it has a lot of radiation, and we as a society are in habit of doing it quite frequently. So why does dyspnea develops post-COVID? Three possible mechanisms: pathophysiology, prolonged pro-inflammatory response may root an atypical response of the mast cells. There may be persistent viral replication after the acute phase, although we have the world has come to a conclusion that even after PCR is positive after 30 days, 15 days, it not necessarily implicate that it is actively multiplying. The third, which is the most feared, is residual lung injury of lung fibrosis. Who gets these dyspnea post acute COVID? Who are more likely? Female gender is more likely than males. Those who have higher number of comorbidities at start with diabetes, hypertension, and whatnot, and those who had higher number of symptoms at the acute phase of infection. So what should we do if you have interstitial lung disease like changes on the CT scan after COVID-19? This observational study used corticosteroids, as one can expect, and the conclusion was that following the SARS-CoV pneumonia, A cohort of patients are left with both radiological abnormalities and physiological and functional deficit. And if you use steroids early, it was well tolerated and associated with rapid and significant improvement. I, at this point, would like to draw the attention of the viewers that steroids have obviously transformed the management of acute COVID, as we all know, the dexamethasone study. But in that paper, it was maximally used at up to 10 days after the onset of hypoxia, which left most of us with an assumption that 10 days is the cutoff, and beyond 10 days you cannot give any steroids, which was in itself a relief, so that we did not indiscriminately continue with steroids, which can have a lot of complications. However, it left behind a significant cohort of patients in whom, if steroids were used judiciously and carefully, that may have helped in prevention of eventual fibrosis. This study looked at whether we should give a high dose or a low dose prednisolone in symptomatic patients with post COVID-19 diffuse parenchymal lung abnormalities. And the high dose was defined as 40 milligram per day to start with for a week, and then tapering up to 6 weeks. So it was a slow taper starting with high dose, and the low dose cohort involved starting with 10 milligram per day and persisting on it for 6 weeks. The drug used was prednisolone, and 65 patients were randomized into each arm. The primary outcome was a reduction in diffuse lung abnormalities. Radiological response was seen in very few patients, whether you used high dose or low dose corticosteroid. However, there was significant improvement in dyspnea up to 90%, oxygen saturation, and 6-minute walk distance, which was quite significant. There were significant number of steroid-related side effects, and hence we should be on the watch out. The take-home message is for our attention, that there was no difference whether you use high-dose prednisolone or low-dose prednisolone for 6 weeks, and as one can expect, there was more side effects in the higher dose. So use small dose up to 10 milligram, persist for it for 6 weeks or 4 weeks, may even reduce to 5 milligrams after 2 to 3 weeks, and watch for side effects and look for objective improvement. What causes persistent dyspnea after COVID-19? We have seen 3 mechanisms, but we shouldn't forget there may be more. And in these 2 reviews and many others, there was hyperventilation, myocardial dysfunction, pulmonary vascular disease, muscular fatigue, and anemia. So at about after a month or possibly after 2 months, if somebody is left with dyspnea and hypoxia, look at their lung functions, particularly if you can do with the DLCO. Look at their radiology, a simple chest x-ray. 6-minute walk distance, in my opinion, is very good and discriminatory, and it should be used. And watch for anemia and myocardial dysfunction. So what should we do with these patients? It's not a simple task of a pulmonologist or ID physician alone. It requires a team of experts, including mental health experts, physiotherapists, etc., to take the patient on. Physical rehabilitation, in most people's experience, is the cornerstone, starting from fairly early even in the isolation, and the patient, if the patient can tolerate. Long-term oxygen is required in some patients. Pick up a cutoff of 90 to 92% at rest or after exercise. Give them supplemental oxygen. Manage the comorbidities, particularly diabetes, go wayward in most of these patients. Support them psychologically and socially, and don't forget vaccination. In our society, obviously focuses on multivitamins, vitamin D, and most societies, in fact, zinc, antioxidants, but consistently there has been no proof of any particular drug being beneficial in reducing symptoms as compared to placebo. Most of these studies, small studies which have been done on these, have been without control, placebo, and there have been no statistical significant difference. Many patients are being treated in the community just like asthma with LABA ICS combination and Montelukast. I just warn that this is not required for every patient. Palliative care. Many patients, unfortunately, well, not many, but few patients end up with symptoms which are there, which are non resolving. So, palliative care is a separate entity. Unfortunately, there are not many experts in this field, but wherever we can get a palliative care expert, get him in touch or her in touch with these poor patients who are bedbound with symptoms. Whatever could be used in medicine you have used, but they are still with ongoing complications. Sometimes we have to take end of life decisions whether you would ventilate this patient or not, whether we should even admit this patient for ongoing severe symptoms. And we have seen quite a number of patients who are there on ventilator for 1 month or beyond, and there comes a question, ethical questions of unplugging the life saving. Unfortunately, in whatever little evidence we have to see about the palliative symptom control, all the evidence is of very low certainty. So one is literally faced up with his own clinical judgment. Um, in many patients, we have seen that the family, that the healthcare, that the doctors consistently try to save the patient from one complication after the other. And I think as physicians, we have to decide somewhere draw the line that this is the end of this patient's problem saga. Think about calling it a day. Obviously, this is a very difficult decision to take. Other palliative care experts or other specialists should be, because your mind actually just stops thinking after a period of time. So, involve other consultants and decide about their code status. So, in summary, a significant proportion of COVID survivors are left with health related issues for months, possibly years, and therefore long term monitoring is needed. This is a message for all of us. A lot of pathophysiology and evidence into intervention is lacking, and this is an opportunity for all of us to put a lot of our efforts in research. It's not a job of one single physician. A holistic approach with multiple specialty interface may help. Physical rehabilitation should play a key role, and all of us should focus on exercises and related things in this. Don't forget psychological support. Many patients may end up in depression, and unless you treat it, they won't improve. And as I mentioned, there is a lot of scope of research for post COVID symptom management. Inshallah Ta'ala, with research and with human efforts, we will see a lot of good things in future. Thank you for your patient listening.
Thank you, Dr. Suhe, for highlighting the importance regarding rehabilitation of COVID-19 patients. Our third speaker is Dr. Javed Akbar. Thus, he is serving as Assistant Professor of Psychiatry at JPMC and is a visiting faculty at Indus Hospital and Health Network. He is a member of Institutional Review Board of JPMC. Dr. Javed also serves as Assistant Editor of Journal of Pakistan Psychiatry Society. His area of interest are bedside adult psychiatry care, child and adolescent psychiatry, suicide and self-harm, and telepsychiatry. He has been running a charity telepsychiatry clinic at District Umakot for the last 6 years. So he will discuss regarding management of agitation in COVID-19 patients. We are moving to a third speaker. So over to Dr. Javed Akbar Dars.
Assalamu alaikum. And am I audible, Dr. Misbah?
Yes, yes, sir.
Thank you. Thank you, Dr. Misbah. आपके तारुफ का भी बहुत बहुत शुक्रिया. Thank you. And I would say Professor Sohail has and Dr. Nosheen has made my talk a bit easier. Let me share the slide and then I'll let you know
Okay, sir.
how and why. Entire screen. I don't know if it's working. Share. Chrome tab. Oh, I believe there's some issue of sharing the screen.
So you are sharing your slides?
Yes, I'm trying to, but it's not giving me the option to share the screen. Oh, wait a second, if this is working. Can you see the presentation?
Yes, sir, I can see now.
Okay, thank you. Thank you so much. So I said that Professor Sohail and Dr. Nosheen has made my talk a bit easier because that as Professor Sohail has just mentioned that it needs a holistic approach. Yes. And as Dr. Nosheen has mentioned that variants are coming and it won't stop. It looks as if it won't stop. Hopefully I'm wrong. Uh, so the more the patient you will see, this thing will continue, the agitation for the patients and agitation even among the doctors and healthcare workers. So moving on with the presentation, the objectives of
Uh, s-
presentation.
Sorry
Yeah,
to interrupt you, sir. Please share
yeah.
the full screen.
Oh, sure. Is it better now?
Yes, sir. Yes, sir.
Okay.
You can proceed.
So, oh, thank you so much. Thank you. And so we'll be talking about the agitation, what the agitation is, and how does it present, and the management of it. So we'll talk about it. Before moving to the agitation, because it's a condition I don't think we'll be able to see or you'll be able to understand without seeing it in person. So I've tried to, I'll show you a video that might help you understand at first, and then we'll move ahead. So let's see a video and then we'll move ahead.
Sir, we will
Yeah.
start the video. Please, वहाँ से फिर audio नहीं आएगी.
Sorry.
So we will start video from here.
Hello, Ms. Jenkins. My name is Dr. Barbieri.
Oh, good.
I was called here because I was told that you are in pain.
Yeah.
I can help you with that.
My
Can you?
stomach just, oh man, it hurts. And
Yeah.
yeah.
Would you mind laying back so I can
Well,
see where it's
sure,
hurting?
I sure will. I sure will in a minute. But right now, I just need to go get a cigarette, and this person will not let me get a cigarette. So if you let me get a cigarette, then man, woo, address the pain. My stomach's killing me. But if
Good.
I can just do this one thing,
Yeah, man. So you are
Then I
actually not
can-
allowed to smoke in here. But I can help you with that. I know you have that desire.
Yeah.
I can give you a patch that will
No,
make
no, no,
that
no,
go
no,
away.
no. So, I need a cigarette. And if I can just slip right by you, and then I can get a door. Why are you doing that? Why are you doing
I'm
that?
just trying to help. I want
Nope,
to help you.
nope. I don't want your help. I don't want your help on a cigarette, okay?
Ms. Jenkins,
Okay.
let's,
Yep,
we're
yep,
gonna
yep,
get
yep.
you fixed up,
Okay.
okay?
Yep.
Everything's
okay.
gonna be just fine.
Okay. You don't know who I am. Oh my God. You don't know who I am. And if you did, I swear to God, you'd let me have, I'm going to show you who I am. I got documents in here, and I have the right last name to be here and get special
I
treatment.
understand.
You guys know, you all know.
I understand that. Would you mind coming here to your bed so I can, examine
Ms.
it
Jag,
and
if
try to
you-
help, please?
If you just lay down for just a second, we'll take care of you,
I'm not gonna lay
okay?
down. I'm not gonna. You need to move! You need to move! You need to move! You need to move! You need to move!
I know you're
You
feeling
need to
bad. I
move.
know you're feeling bad. But if you sit down, you lay down on the bed, we can take care of you, okay?
I need a cigarette.
Here.
Okay.
All right.
Okay.
We'll get you fixed up,
It
okay?
hurts. I really need some help. I
Huh?
really need some help.
All right, I'm gonna,
I really need some help.
I'm gonna
I need a
get some
cigarette.
medicine.
Stop!
You know,
Whoa.
well,
I think we better get security.
Can we get security, please?
Stop! Just stop! Just stop! Oh God.
Yeah, can we have security up here in room 5?
I know I can't.
Yeah, right away.
I
Thank
know
you.
there's- What happened?
What I believe you all have observed the restlessness the patient was facing, irritability. There was like purposeless, or I would say semi-purposeful movement that she was moving here and there, and there was heightened responsiveness. She was responding even to minimum stimuli. So, if we just explain, it will say that it is an excessive motor activity that is associated with feeling of inner tension. Inner tension. So that's what agitation is. It is usually repetitious, and it is non-productive, as you have just witnessed in the videos. Even aggression or violence are not the core features of the agitation, but if the situation continues, it might end in agitation, in the violence and aggression. So clinicians have divided into three main types. There are agitation which is physically non-aggressive. There is agitation which is physically aggressive behavior, and there is verbally agitated behavior. So these are the three types. Agitation has been associated with so many psychiatric illnesses also, like with schizophrenia, with bipolar affective disorders, and dementias like Alzheimer's, as well as the organic situations like encephalitis, thyrotoxicosis, even hypoglycemia, and brain injuries, etc. The third thing, the cost or the burden of care. I couldn't find any local study on that thing, but I've I've seen a study that says that almost 1.7 million emergency department visits may include agitated behavior. So that may very well explain the economic cost attached with this behavior, and how and why we should care about it and in dealing with this situation. There are many, I would say, stages of the agitation and violence, which we all observe among the patients, that ranges from angry or frustrated behavior to pacing, restlessness, footstepping, clenching fist, to moving on to the invading the space of the doctor of the area. So, what are the risks involved in such situation? What are the risk factors, I would say? The risk factors are usually impulsiveness, what we should be careful of before while taking our the history of the patient. That's impulsiveness, hostility, non-voluntary admission if they're coming to the hospital. There is younger age, being unmarried, history of any psychiatric illnesses, destructive behavior in the past, history of suicidal attempt or behavior, substance use. All these factors should be taken into account before moving towards the patient who has shown aggressive behavior or aggression. And if you look at the psychosocial effects, if you can see the picture, psychosocial effects may, first of all, is the environment of the ICU. What does a brain needs? Brain needs usually a circadian rhythm and the nutrition, and that can be provided by dietary supplements and the environment, familiarity with the environment, like natural light or the frequent orientation, which is usually missing. And anyone in the atmosphere of ICU, like constant beeps of ICU equipment that we observe, there's a losing of complete autonomy of the patient, surrounded by people with such stresses, with all the healthcare in this stresses. If you just see the scenario from the eye of a patient, then you will very well understand the psychological effects the patient might be going through in that situation. A person who was all in all a couple of days back, who can do everything on its own, and now he's completely surrounded. He just cannot do anything without the permission. Now, this dependency, this makes a patient helpless and hopeless. With such situation, with such stressful situation, and with the fear of like not knowing what's going to happen, as we were well aware of the first wave and its lethal outcome that the whole world has observed, this results in sleeplessness, disturbance in sleep, appetite, and this agitated behavior and anger and violence. While moving towards the management, I'll again ask my colleagues if they can play the second video, and I'll explain what's the importance of that second video is. Dr. Misbah?
Victor, I'm Dr. Lee. Look, I heard you were screaming on the streetcar. What was that all about, man? Victor? Victor? Hello, so I need you to like answer some of these questions, you know, like the police brought you here, and you basically have to answer some questions, otherwise you can't leave.
I want to leave.
So let's get this clear. You're not allowed to leave until we talk a little bit here, okay? You hear me?
I want to leave.
Victor, settle down, okay? You hear me?
I want to leave, please. I just want to go home.
You need to settle down right now, okay? Otherwise, I'm going to have to call security.
I want to go home.
Victor, settle down.
I want to go home.
Security. Security. Victor, I'm Dr. Lee. What's going on? I heard you were upset. You were shouting on a streetcar or something like that. Want to tell me about that? What was that, Victor?
I want to leave.
Okay, all right. I can see you're a little upset. Okay. All right. Why do you want to leave, Victor? What's the matter?
My head hurts.
All right. Okay. All right. Well, I'm a doctor. Maybe I can help you with the fact that your head's hurting, okay? Now, I know you got very upset before on the streetcar, right? Just, I can see you're trying to stay calm now, you know? But hey, look, you're doing a good job, okay? I understand you're getting a little upset, you're afraid, but we're going to try and help you, okay? We're here, the hospital, we're here to try and help you, okay? We're going to try and do our best. All right, so why don't you tell me about your head? What's going on there?
It really hurts at the back.
Yeah.
You know, like right here.
Did you fall? Did anybody hit you?
No.
No.
No, it's just boom, 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 boom. You know, like thing.
Yeah.
I can't really explain it.
Yeah. And is that why you started screaming on the streetcar? Okay.
Yeah, I'm really sorry about that.
Oh, that.
I
very
really
nice.
apologize. I'm usually not like that.
That's very nice of you to say that. Okay, it's all right. I'm glad everything worked out okay. Is there anybody with you, Victor? Is anybody I should be calling?
Yes, my sister.
All right. Okay. Great. I'm going to try and get her phone number.
The same scenario was same, the doctor was same, only the principles that he has followed, that you have observed. So there are general principles for the management, and there are some specific principles. And the general principle first of all comes the verbal de-escalation that you have just observed in the video. He was not confronting, he was not authoritative, but he was firm what he wants from the patient. And secondly comes the training of healthcare worker. It is not a one-man's job. It is, as we have observed, it is a collaborative work, this managing the agitation. Then comes the specific principles that include various things. What we usually practice here is the first generation antipsychotics, as we don't have the availability of second generation antipsychotic in the injectable form. But the second generation antipsychotic like risperidone, quetiapine, they are usually preferred in the agitation management of agitation. But because the availability is here only with the haloperidol, so that's why we use the first generation haloperidol. The only side effect that we usually observe is extrapyramidal symptoms of dystonia. And at the end, this comes the physical restraint of the patient. So if we'll just look for the general principles, these are the few basic things that we should keep in mind, that we should keep a safe distance. And if the patient is standing, we are not supposed to sit, we should be there. We have clear or keep an eye that the exit is available, there is a clear exit. Don't keep your eye away from the patient, because as we have just mentioned earlier, the agitated behavior may turn into aggression and violence, and you need to take care of yourself also. The voice should be low, but there should be a firm approach to the patient, and try to talk to them to agree for the medicines. For these specific principles, there it has been divided into three, mainly the behavioral, as we have just mentioned. The limit setting, you need to explain to the patient that what the objectives are at that particular moment, and at times you need a show of force also. That in the earlier video, the doctor and the nurse, they were showing them. Then comes the medication. Obviously, as we have just mentioned in the medicines, it's a teamwork, collaborative work, and the chemical lock or rapid tranquilization can be treated. And in the end, the physical restraint of the patient if the other things are failing off. So, in the last, I would just say it is the managing the agitation. It is always provide what we should do is we should provide a person centered, because it's different from person to person, recovery oriented, trauma informed, family inclusive, gender and sexuality sensitive, and culturally appropriate care. So that's how it should be. Thank you so much for your time, and I'll be happy to take any question if there are.
Actually, we have seen so much cases, see such cases on daily basis in COVID unit. So your session really helped in managing these situations. So we would like to welcome any. We will be discussing question and answers. So first question is for Dr. Nosheen. Can you hear me?
Yes, I can, Misbah.
Ma'am, it's what of the new options do we have for Pakistan, that is monoclonal antibody and oral treatment?
All right, so that is a sort of a difficult question to take on because we know that the monoclonal antibodies have a huge cost associated with them, and it is very less likely that they will reach the markets in Pakistan anytime soon. Or even if they do, that they will be utilized for patients anytime soon because of the huge cost which is associated with them. There are trials which are underway. There's at least one trial which the Khan University is conducting. It's not a neutralizing antibody. It is, however, a monoclonal antibody with some antiviral activity, and that is just being utilized as part of clinical trial. But we don't have monoclonal antibodies here. As far as the newer drugs, so Paxlovid is, we have heard the news that it may be coming to Pakistan, but not anytime soon. We have heard that the earliest that it might come would be in March. But those are the only two that I've heard of, which may be. So Regdanivimab was coming to Pakistan, and so these are the two ones that we may be potentially seeing in the future. And we will see how much cost is associated with them and how they can be utilized in our population.
Okay, ma'am, there is another question for you. Why we shorten the isolation period for Omicron variant?
All right, so this is a tough one to take on as well. This has been, this is still a moot point, I would say. There's a huge debate going on whether we can reduce the duration of isolation. A lot of these recommendations are being made in view of public health implications of a longer isolation periods, because there has been gross understaffing at hospitals and healthcare facilities because of the immense transmissibility of the Omicron variant and the number of cases that the centers are seeing. So a lot of these guidelines are drafted as part of public health, for public health benefit, and may not have direct evidence backing these guidelines. So a lot of the research is underway. So I've gone through the research. So CDC does not, a lot of it is being adapted from CDC, from the US guidelines. And we know that they had a massive surge and they ran short of their staff. But as far as I can see, they have not cited any data as evidence for their recommendations. But what they are using are projections. So a lot of the data is created by anticipating what might happen, or how many people may get infected. It is being assumed that the vaccine would reduce the infectivity period of a patient, and some of this is being used as a rationale for reducing the isolation periods. But we still need data with regards to how long. The most recent study that has been published, January 14, in IJID, it said, it concluded that 1 in 3 may still be infectious after reducing the isolation period to this date. So we are still grappling with data, and more, as more research becomes available, we will be revising accordingly.
Thank you, ma'am. There's a question for Dr. Sohail Akhter. Sir, can you hear me?
Yes, I can.
Sir, this question: do you think that healthcare workers are ignored and showed less sympathy when can be going through long post-COVID symptoms due to the need of their expertise?
अ, अगर इस सवाल को मैं सही समझाऊँ तो डॉक्टर फिज़िया ये पूछना चाह रही हैं कि हेल्थ केयर वर्कर्स जो हैं ख़ुद बज़ाते ख़ुद जब वो कोविड से निकल कर आते हैं और लॉन्ग कोविड सिम्टम्स, पोस्ट कोविड सिम्टम्स हो रहे होते हैं, वो ख़ुद इग्नोर होते हैं। अगर यही सवाल है तो मेरा ख़्याल है कि इसका जवाब तो मुझे नहीं पता कि प्रोपोर्शन क्या है, ज़ाहिर है कोई रिसर्च मेरी नज़र से नहीं गुजरी है, लेकिन इग्नोर हो सकते हैं क्योंकि एक महाज़ जंग खुला हुआ है, लोग शॉर्ट पड़ रहे हैं, हॉस्पिटल्स में पेशेंट हैं, उनको देखने के लिए डॉक्टर्स चाहिए, तो ये हो सकता है। मेरा ख़्याल है कि हर सिस्टम को, हर हॉस्पिटल को एक पोस्ट कोविड असेसमेंट का कम से कम डॉक्टर्स के लिए ज़रूर एक क्लिनिक होना चाहिए जिसमें उनको कोई एक्सपर्ट जो है वो डील करे बहुत ही बेसिक से सवाल जवाब के साथ और फिज़िकल एग्जामिनेशन के साथ, और इन दोज हु हैव वन और फ्यू सिम्टम्स शुड बी फॉलोड अप, and obviously their need to rejoin or not should be assessed pragmatically. ये मेरा ख्याल है कि हम जनरली वो 10 days और 5 days का करके फिर वापस आना, ये एक सिस्टम में हमारी ज़रूरत है, हर सिस्टम, हर हॉस्पिटल की।
Thank you, sir. There's another question for Dr. Nosheen. Can you hear me?
Yes, I can hear you.
Ma'am, there's a question. What is the role of CT value in de-isolating asymptomatic COVID, yet high CT value like 2024?
So there is no role as such of CT values in discontinuation of isolation, and we've pretty much abandoned this doing CT values for discontinuation of isolation. So I would not recommend doing that, and the literature also does not support using CT values as a guide for discontinuation of isolation. There are newer tests that may be more reflective of the infectivity of a patient. There is a form of RNA PCR, which is being studied as one of the ways which can predict infectivity better than other tests, and they may be coming up soon. Similarly, serological tests, the advances in serological tests maybe maybe coming up for determining the infectivity, but CT values certainly do not give us any clue in terms of discontinuation of isolation.
Thank you, Dr. Nosheen. There's a question for Dr. Javed Akbar. Sir, can you hear me?
Yes, I can.
Sir, what we can include on our ICU setup as a baseline to reduce patients' agitation?
Okay, thank you. There have been studies that if we address the sensory stimulation in terms like the beeps of ICU equipments, वो अगर बार बार इतनी सुनी जाती हैं तो उससे एजिटेशन बढ़ती है. There has been studies जो इसी sensory stimulation में यही कहा जाता है कि if they can visualize the outside atmosphere, like there are windows or something that the patient can see outside, either it's a daytime or a nighttime, that even reduces the agitated behavior. Number third is the repeated change in the worker ICU, the staff. जल्दी जल्दी चेंज स्टाफ अगर होते चले जाते हैं तो अगेन उससे फेमिलराइज इंसान नहीं हो पाता, देन अगेन दैट रेजेस द एजिटेटेड बिहेवियर. उसके अलावा द वे वी टॉक टू द पेशेंट एट दैट पर्टिकुलर टाइम, अगर इफ अ टोन एंड अवर इज नॉट हाई बट इट्स फर्म, वो भी इट्स reduces the agitated behavior.
Thank you, sir. Sir, I need to ask one more question from my side. We are seeing that antipsychotic drugs are causing prolonged QT interval. So we are using so many drugs in the ICU setup. So what are the other options we can do? We can use for managing that agitation?
It all depends on the dose of the medication. No doubt QT interval का options या कोई इसके side effects रहते हैं, but still if you consider the dose of the medication and if you choose the second generation antipsychotics, तो उसमें अगर आप you starting with the 1 milligram, but what we do is we rapidly titrate the dose and we don't wait for a while because of the condition. So we should be taking care of the risk factors that have been mentioned in the presentation, and secondly, then the antipsychotics option of antipsychotics. There is option of benzodiazepine also, but again, we don't have the injectable availability of lorazepam, and secondly, the paradoxical reactions of benzodiazepine. So that's why we usually avoid and we go for the antipsychotics.
Thank you, sir. There's another question for Dr. Sohail. What are the rehabilitation facility for COVID in Pakistan? Is there any role of antifibrotic drugs?
एंटीफाइब्रोटिक ड्रग्स का तो अब मिडल ऑफ 2020 से स्टडीज़ चल रही हैं. परफेनाडोन इज़ अवेलेबल इन पाकिस्तान एंड इज़ यूज्ड फॉर idiopathic pulmonary fibrosis, but there has been to date, to my knowledge, no conclusive evidence that it benefits the fibrosed patients or those developing into fibrosis. जैसे कि मैंने अपनी प्रेजेंटेशन में बताया कि बहुत सी apparent fibrosis जो हमें CT स्कैन में नज़र आती है, those changes go away with time with a little bit of steroids and whatnot. So up until evidence is available, I think we should not use the antifibrotic agents. पहला सवाल आपका क्या था? रिपीट करेंगे?
The first question was, what are the
rehabilitation centers जो हैं वो साइंटिफिक जो अगर इसकी करनी है तो मेरा ख्याल है बहुत थोड़े हैं, बट अगर बहुत थोड़े भी हैं तो जहाँ पे नहीं मौजूद हैं वहाँ मेरा ख्याल है कोई ज़्यादा इसमें लंबा चौड़ा इन्वेस्टमेंट नहीं चाहिए होता. अगर किसी भी हॉस्पिटल सेटअप में इंटरेस्टेड डॉक्टर्स, ज़रूरी नहीं है कि वो फिज़ियोथेरेपी में ट्रेंड हों या पल्मोनोलॉजी में ट्रेंड हों, अगर थोड़ा सा इसके लिए अपनी एफ़र्ट्स को जमा कर सकें तो थोड़ी बहुत उसमें फ़िज़िकल थेरेपी की ज़रूरत होती है, साइकोलॉजिकल काउंसलिंग की ज़रूरत होती है, इससे बहुत ज़्यादा कुछ नहीं चाहिए होता. जहाँ पे मौजूद हैं वहाँ तो बहुत अच्छी बात है, लेकिन मैं ये पॉइंट इसलिए स्ट्रेस कर रहा हूँ कि मुझे मालूम है कि बहुत थोड़े सेंटर्स फ़िज़िकल थेरेपी और रिहेबिलिटेशन को डील कर रहे हैं. तो हमें इस खुद 2-3 इंटरेस्टेड डॉक्टर्स मिलकर इसको हर हॉस्पिटल में सेट कर सकते हैं. समथिंग इज़ बेटर देन नथिंग वाली बात है.
Thank you, sir. There's another question for Dr. Nosheen. Since 53% of eligible population is already vaccinated, and a large number of population has already been infected and have some residual immunity. So the new variant is very much milder in clinical presentation. Do you think lifting restrictions and letting COVID run its course would be a viable option?
All right. So this question has different like this is the main concept that is being by public health physicians and public health representatives, that this is the evidence that they share, that most of the population is vaccinated, most people are getting milder disease. And those are the kind of and there's another aspect to it that one needs to see, that there are those people also who eventually develop a severe disease, who may die due to this disease. And you have to see it from that perspective also, in terms of when you want to make this kind of a decision. And so why, it's like, why put those people at risk who are going to be developing severe disease? We know that this Omicron variant has reduced further the chances of herd immunity, and running its course would mean a lot of people would die, similarly as we did for when in the beginning of the pandemic, when we had the virus. Is the same argument that you can make, that there will be the other end of the spectrum also, and we need to look at it from that perspective. Moreover, we also need to look at it from the perspective of the overwhelming conditions of the healthcare facility. I mean, if there's a massive influx of patients, that you would not have a lot of and especially when your workforce will also decline because of disease, and how will you handle that? This whole assumption based on is a milder disease and it's going to run its course in majority of the patients in a mild manner is not enough of an argument for lifting restrictions and letting COVID run its course. But I'll be happy to hear the thoughts of the other panelists with regards to this statement. Dr. Sohail.
Sir, Dr. Nosheen wants your opinion.
ये अच्छा है, कंट्रोवर्सी में मुझे आप इन्वॉल्व करना चाह रही हैं. मेरा ख्याल है कि मेरा ज़ाती ख्याल ये है कि ओमाइक्रॉन वर्सेस ऑल अदर वेरिएंट्स, सारी हमारी स्ट्रैटेजी इस वजह से चेंज हुई है. एंड वैक्सीनेशन वर्सेस नॉट वैक्सीनेटेड, अगर इन दो फैक्टर्स को बैलेंस किया जाए तो मेरा ख्याल है सिस्टम्स ने, देखिए हम अपने एंगल से सोच रहे होते हैं और हम जस्टिफाइड होते हैं, और गवर्नमेंट्स वगैरह अगर पॉलिटिकली ना सोचें और मतलब रैशनली सोचें तो वो अपने एंगल से उनकी अपनी रीजनिंग होती हैं. मैं जो दो फैक्टर्स कह रहा था कंपैरिजन का, वो माइक्रोन इतना ज़्यादा फास्ट स्प्रेडिंग वेरिएंट है, हम सब की ऑब्जर्वेशन है कि अगर इसमें हमने बड़ी तादाद में 10 डेज़ का आइसोलेशन फॉलो किया, और कंसिडरिंग ये कि वो माइल्डर भी है, तो फिर व्हाट विल बी द सोसाइटी बी लेफ्ट विद. तो ये बैलेंस वाला मैकेनिज़्म जो है मेरा ख्याल है उसको टिल्ट करके 5 डेज़ तक ले गया है. मेरा ज़ाती ख्याल ये है कि दरमियान का एक रास्ता ये होना चाहिए कि 6th डे पे रैपिड एंटीजन टेस्ट कर लिया जाए, और जो नेगेटिव हैं, ख़ासतौर पे हेल्थ केयर वर्कर्स की मैं बात कर रहा हूँ, दे कैन जॉइन. फिर हेल्थ केयर वर्कर्स में भी देर आर कैटेगरीज. वन कुड बी अ रिसेप्शनिस्ट सिटिंग बिहाइंड द ग्लास, एंड वन कुड बी एन ICU टेक्नीशियन इंट्यूबेटिंग पेशेंट्स. तो दोनों के उसमें फ़र्क है. ऑफ कोर्स इन आवर हॉस्पिटल देर आर HR and their pharmacy people, so they are not directly related with patients. तो अगर इनको भी डिस्क्रिमिनेट कर दिया जाए, फॉर एग्जांपल कैटेगरीज बना दी जाएं कि वो जो इंटीमेट कांटेक्ट में रहते हैं और एरोसोल से एक्सपोज होते हैं, एंड पर्टिकुलरली वो जो पेशेंट्स के साथ काम कर रहे हैं और उन कोविड पेशेंट्स के साथ, उनको अलग कैटेगराइज कर दिया जाए, लेकिन बाकी सबको 5th डे पे रैपिड एंटीजन करने के बाद वापस सिस्टम में लाया जाए, तो ये ज़्यादा मेरा ख्याल है बेहतर होगा। इसका जवाब तो ज़ाहिर है कोई गवर्नमेंट ही दे सकती है। मुझे अभी आज ही सुबह ही मालूम हुआ है कि आईडी स्पेशलिस्ट खासे अपसेट हैं इस बात पे कि उनकी ओपिनियन को इग्नोर किया गया, लेकिन मैं गवर्नमेंट को कोई साइड भी नहीं ले रहा। दिस डिसीजन वाज नॉट आस्क्ड मी, लेकिन मैं एक रैशनल बात कर रहा हूँ कि आपको कहीं ना कहीं बैलेंस रखना होता है। थैंक यू।
Thank you, sir. There's another question for you, sir. Is there any role of pulse steroids after initial steroid for acute COVID who is having persistent ground glass and high oxygen requirement?
अच्छा, मेरा ख्याल है कि नहीं, जवाब आपके उसका है नहीं। मुझे ऑफ द हेड इस पर्टिकुलर पे कोई स्टडी तो याद नहीं आ रही, ऑल्दो स्टार्टिंग विद पल्स मिथाइल प्रेडनिसोलोन वर्सेस जो डेक्सामेथासोन हम इस्तेमाल कर रहे हैं 6 to 8 मिलीग्राम पर डे का, इसकी स्टडीज़ तो हैं और उसमें कुछ बेनिफिट शो किया गया है। लेकिन आप स्पेसिफिकली ये पूछ रहे हैं कि आपने 5 या 10 दिन डेक्सामेथासोन दिया या प्रेडनिसोलोन दिया और उसके बाद इफेक्ट नहीं आया, तो उसके बाद आप पल्स थेरेपी दें। मेरा ख्याल है इसके कोई ना एविडेंस कम से कम मेरे इल्म में है और ना इसका कोई रैशनल बनता है, क्योंकि बेसिकली ये एक हाथ पांव मारने वाली बात है डेस्परेशन में। और हमने स्टेरॉयड से ख़राब होते हुए पेशेंट्स बहुत देखे, हम सब ने देखे, मायोपैथी और सेकेंडरी बैक्टीरियल इन्फेक्शन, डायबिटीज़ एंड यू नेम इट। तो जो हम लंग्स को, हाइपोक्सिया को बेहतर करने के लिए जो हाथ पांव मारते हैं, बहुत सारे और सिस्टम्स उनसे ख़राब हो जाते हैं। ऑन दी कॉन्ट्ररी, हमारी अपनी ऑब्जर्वेशन और मेरा ये फर्म बिलीफ है कि कंटिन्यू विद लोअर डोज फॉर प्रोलॉन्ग पीरियड्स, इससे सक्सेस जो है वो, यानी कि थोड़ा सा सब्र करें, एक्सपेक्ट ना करें कि 2 हफ्ते में पेशेंट की एबनॉर्मैलिटीज़ दूर हो जाएंगी। गिव हिम अ मार्जिन ऑफ 6 weeks or 8 weeks. Give a little lower dose, 5 milligrams per day. Even I've seen in many of my patients, that does wonders, provided you give them for a long period of time.
Thank you, sir. Thank you, Dr. Sohail Akhter, Dr. Nosheen, Dr. Javed Akbar Das for your answers. It has cleared many queries of our audience. So we are moving to our oral fee paper presentation sessions. So our first oral presentation will be Dr. Iffat Khanum, Assistant Professor, Infectious Disease Department at Khan University and Hospital. She will present on awake prone positioning in the management of COVID-19 patient. Over to Dr. Iffat Khanum.
Assalamu alaikum. I'm Dr. Iffat Khanum, and I'm assistant professor at Khan University Hospital. The title of my study is Awake Proning in Patient with COVID-19, and these are my co-investigator. Severe illness characterized by progressive apocalyptic respiratory failure develops in large number of patients with COVID-19 that results in prolonged ICU stay, invasive mechanical ventilation with profound effect on morbidity and mortality. Prone positioning has been shown to improve the oxygenation for decades, and majority of the cases it has been applied in patients with ARTS and who are on mechanical ventilation. However, proning in awake, non-intubated patients gained widespread acceptance and popularity in the onset of current pandemic. There's a limited evidence about the efficacy of conscious prone positioning without invasive ventilation in COVID-19 patients who have hypoxemia. The objective of current study was to evaluate the efficacy of awake prone position in hypoxic, non-intubated patients with COVID-19 within this geographical area. The primary outcome was avoidance of intubation, and secondary outcome were in-hospital mortality and the length of hospital stay. We had conducted a prospective observation study of adult patients admitted with severe and critical COVID-19 between July to September 2020. Patients received awake prone position early on after admission as a part of their treatment strategy
Along with the standard of care, they were compared with those who received standard of care alone. The assessment for initiation, frequency, and duration of each session of pruning was based on the assessment of primary physician as well as respiratory therapist. We took patients' informed consent as well as patient cooperation and tolerance was also considered before starting this maneuver. The patient who were not able to receive prone position due to some reasons like contraindication for prone position were there, or patient was not able to tolerate prone position were included in the control group. Patient received prone position with invasive mechanical ventilation were excluded from the study. A total of 98 patients with COVID-19 treated with awake proning were compared with 98 patients treated with standard of care alone. The mean age of patient awake prone group was 56.1 years, while mean age in control group was 55.7 years. Majority were male in both groups. There was the more frequent comorbid illness in both groups were hypertension, diabetes, and ischemic heart disease. Critical COVID-19 was present in 50% of patients treated with prone position, while 35% patients managed with standard of care alone had the critical illness. The mean duration between admission and initiation of prone position was 3 days. The median days of proning were 4 days. The minimum number of hours of awake proning tolerated by patient were 2 hours per day, and maximum hours tolerated were 16 hours per day. There was no major complication related to awake prone position was reported during the study period. Among radiological findings, there were predominantly bilateral lung infiltrate on chest radiograph in both groups. However, a comparatively high number of patients presented with multilobar lung involvement in prone groups as compared to those who treated with standard of care alone, with a p-value of 0.001. Although the mean PF ratio at the time of admission was significantly lower in patients treated with awake prone position as compared to control group, but with the passage of time, both groups have shown significant clinical improvement in PF ratio by the time of discharge. The median length of stay in special care was comparable in both groups, that is 4 days. The median length of stay in the hospital in both groups was also comparable, that is 8 days for prone position group and 7 days in control group. The use of awake prone position did not reduce the risk of intubation, invasive ventilation. 8.1% patient in prone group and 5% control group required intubation, and that difference did not reach statistical significance. The overall mortality in the study the overall mortality among the study participants was 10.3%, and which was similar in both groups. The cause of death in majority of the study participants was ARDS, followed by septic shock and multi-organ dysfunction. ARDS leading to death was more common in patients who were not treated with standard of care alone as compared to those who received prone position ventilation with a p-value of 0.02. In conclusion, awake prone position can be considered as a safe, cost-effective, and adjunctive therapeutic option that has shown to improve the oxygenation in patients with COVID-19. It may slow the respiratory deterioration in selected patients with COVID-19 who require oxygen supplementation or non-invasive ventilation. This in turn may reduce the demand for invasive mechanical ventilation, thus helps in reducing the pressure placed on intensive care services around the world. It may not successfully prevent all intubations, and its impact on other clinical outcomes like survival and duration of hospitalization is uncertain. It can be included in home-based management protocol of COVID-19, and it helps in decreasing the burden of healthcare facilities, especially in resource-limited settings. Thank you so much.
There's a question for Dr. Muniba. Ma'am, you are here?
Yes, I am.
Ma'am, I would like to ask, what are your comments on awake proning?
So, awake proning is a very effective maneuver which can be done because it increases the oxygenation of the lung by increasing the surface area. It's very helpful, especially if it is started early. Like you don't have to wait for the patient to become critically ill and then only you can go for it. If the patient is in the HDU and the oxygen requirements are increasing, that very moment you can ask the patient to either laterally prone himself or complete prone himself, and that really helps in increasing the oxygenation of the lung. And it is also a very important part of treatment of COVID-19. Dr. Iffat is also here, and she can also comment on that.
Yes, Dr. Iffat.
Thank you, Dr. Muniba. So I agree with you that it has been found a very useful maneuver, especially in those patients who are in HDU and ward setups, and we have seen a beneficial effect. But the most important factor which we have identified is the patient's cooperation. So if patients willingly, I have seen marked improvement in those patients who have a prolonged extended hours of proning as compared to those who are not able to remain in the same position for a long period.
Um,
Thank you, Dr. Muniba. Thank you, Dr. Iffat Khanum, for your answers. So
Thank
now
you.
we are moving to our second pre-paper presentation. It's by Dr. Zaheer-Uddin. He is an assistant professor at SIUT. So he will be presenting on outcome of COVID-19 in renal failure and tolerance of remdesivir. So over to you.
Assalamu alaikum. My name is Dr. Zaheer-Uddin, and I am working as an assistant professor in infectious disease department at SIUT hospital. And today the topic of my presentation is outcome of COVID-19 in renal failure and tolerance of remdesivir, experience from a large renal and dialysis center in Pakistan. Patients with renal failure are at increased risk of progression to a severe form of COVID-19 with high mortality, 25 to 30%. Whether remdesivir increases the risk of AKI in patients with COVID-19 is still uncertain. Remdesivir is not indicated in patients of severe renal impairment unless benefits outweighs risk due to scanty safety data. So here I would like to share some work done previously, and this was a study done in India by Akhter et al. Reported no significant renal impairment with remdesivir in patients with AKI or CKD, but limitation was numbers were few and no controls for comparison. Another study by Petit et al. From USA, a single center comparative study on patients with severe renal impairment found to have serum creatinine elevation in 27% versus 11% in control group, not statistically significant between the two groups. Another study from Italy, retrospective observational study, 109 individuals also did not find any significant renal impairment who patients who received remdesivir. So our aim and objective were to evaluate the outcome of patients with renal failure who received remdesivir in terms of mortality, and to study the safety of remdesivir, especially in patients with compromised renal functions. This was a retrospective observational study from June to November 2020. We included all patients more than 18 years with COVID-19 having saturation less than or equal to 94 and received remdesivir. We excluded transplant recipients. Patients were divided into renal failure and non-renal failure group. Demographic comorbidities, inflammatory markers, and ICU stay were compared between the two groups. Renal and liver functions among patients were observed at day 0, 5, and 7 of remdesivir. Our primary endpoint was mortality at day 28 and adverse effect from remdesivir. And our secondary endpoint was to find out the risk factor associated with mortality between survivor and non-survival in renal failure group. Overall, we had 142 patients receive remdesivir. Out of those, 38 in renal failure group and 104 in non-renal failure group. Mean age was 55.93, and no difference were observed between the two groups. But in both the groups, the patients were elder, more than 45 years of age, as compared to younger patients. There was no any significant difference regarding the gender. Male were 63.2% in renal failure group versus 66% in non-renal failure group. But when we saw the coexisting medical conditions, what we found out that 84.2% in renal failure group have comorbidities other than renal failure, as compared to 60.6% in non-renal failure group with a p-value of less than 0.008. And more patients in renal failure group were hypertensive, 68.4% versus 30.8% in non-renal failure group with a p-value of less than 0.001. Regarding the symptoms, the fever was most common symptom, followed by cough and shortness of breath, but we did not find any significant difference between the two groups regarding the symptomatology. This was the table showing laboratory parameters on admission, and these are the median laboratory values, and we found out that CRP was 12.5% in renal failure group versus 7.6%, and ferritin was also high, 1180 in renal failure versus 431 in non-renal failure group with a p-value of less than 0.001. And D-dimer was also high, 2.52 versus 0.64%, with a p-value of less than 0.001. Overall, 24 patients were died, comprising 16.9%, and 28.9% in renal failure group and 12.5% in non-renal failure group died, with a p-value of less than p-value of 0.021. When we saw the risk factors of mortality in renal failure patients, we did not find any significant difference regarding the risk factors of mortality, the gender, comorbidities, laboratory parameters, and treatment. We did not find any significant difference between the two groups. This was the median serum creatinine in renal failure and non-renal failure groups, and we can see that in renal failure group, the median serum creatinine was 4.59 on admission, and it came down to 3.92 at day 5 and 3.87 at day 7. While in non-renal failure group, the median serum creatinine was 0.88 and 0.94 at day 7. This was the 6-point ordinal scale in non-renal failure group, and we can see that 55% of patients were on a room air on admission and 39% on oxygen. And on day 14, 83% of patients were discharged, while 12% of patients died at day 14. In renal failure group, we can see that 63% of patients were on oxygen on admission, and at day 14, 63% of patients were discharged, while 5% of patients were still on oxygen, and 6% of patients were died at day 28. Oh, sorry, day 14. So in conclusion, COVID-19 in renal failure presents with severe disease carrying high mortality. Coexisting medical condition and raised inflammatory markers on presentation more frequently found in non-survivor renal failure patients. In our cohort of patients, remdesivir was well tolerated and no patients required discontinuation of drug. Remdesivir did not increase the risk of AKI in hospitalized COVID-19 patients. Thank you.
Thank you, sir. Thank you for your presentation. Thank you, Dr. Zahi. Sir, we congratulate on getting first prize on e-poster presentation, oral presentation. I would like to have Dr. Tareem on board. I need to ask her experience. Ma'am, are you here?
Hello.
Can you hear me, ma'am?
Yes, I can hear you. Can you hear me?
Yes, ma'am.
Okay.
Ma'am, I would like to ask your experience. As you have seen so many transplant patients, what are your experience of remdesivir at your institute?
Yeah, sure. Thank you, Ms. Ba, for first of all for letting me share this very interesting session. हमारे पास raw में we are seeing the triple transplant patients, bone marrow, liver,
Ma'am, there is so much distortion on your side. Ma'am, we are taking you on call. Hello, Assalamu alaikum, ma'am.
Can you
Ma'am,
hear me?
ma'am, please share your experience on.
So, Ms. Ba, thank you very much for letting me share this session. हमारे पास रॉ में ट्रिपल ट्रांसप्लांट है, बेसिकली बोन मैरो ट्रांसप्लांट, किडनी और लिवर ट्रांसप्लांट तीनों। एंड इंटरेस्टिंगली जो ट्रांसप्लांट पेशेंट्स हैं उनमें सिवियरिटी काफी कम नजर आई है हमें एज कम्पेयर टू दिस जनरल पॉपुलेशन. So in the sense, we have given them decibel very liberally. Sometimes we used to consult Dr. Zaheer and Dr. Asma from SIUT, and sometimes Muniba City consult करके. So we have given them the काफी liberally हमने इनमें दिए, even in renal transplant patients, and we did not see a single patient having worsening of LFTs and in our clinical practice. Of course, I do not have numbers and data right now, or worsening of AKI in these patients. Of course, there were the patients who developed multi-organ failure later on, but there were many different factors, their comorbidities, their age-related factors, and other factors, a very high D-dimer level, which may be the contributing factors in their acute kidney and liver injury. But solely with remdesivir, I did not see a single patient who developed necrotizing hepatitis or very bad transaminitis or severe AKI. So I had a very good experience with remdesivir, even in patients with renal failure and transplant.
Thank you, ma'am. Thank you for sharing your experience. I would like to ask Dr. Zaheer experience. Sir, can you hear me? So are you there? I need to ask one thing. If a GFR is less than 30 ml per minute, so there is a deposition of beta cyclodextrin sodium salt compound in the renal patients. So is it accumulates in renal patients when there's a functions decrease? Have you seen such cases? Sir, can you hear me? Dr. Muniba, can you answer this question? Can you share your experience?
Yes, it's been mentioned that whenever the creatinine clearance is less than 35%, there is accumulation of cyclodextrin. But we also need to look that in COVID, we are giving remdesivir only for 4 days. And we haven't experienced any such thing like worsening of AKI. They can be, you need to weigh it, no? Whether it's giving benefit or the risk of worsening is so bad that the patient can have more morbidity compared to the benefit of giving remdesivir. So I think 4 days does not cause that much harm. I have seen patients with transaminitis in which I need to hold this, but the ratio or the percentage is only 1%. So, but you really need to know when you need to give remdesivir. It is when the symptoms are of less than 10 days, because it works only in the phase of viremia, more when the symptoms are of less than 7 days, and the patient is hypoxic or the X-ray has infiltrates. So it really helps in settling down the patient's persistent fevers and the clinical status. And accumulation of it may be more when you give it for more than 4 days, like for 10 days or so.
Thank you, ma'am. Thank you, Dr. Zaheer, thank you, Dr. Tahreem, and Dr. Munifa for clearing our queries. So now we are moving to a third free oral paper presentation. This will be given by Dr. Saba Shahid. She is a consultant pediatrics at Indus Hospital and Health Network. Her topic of discussion is comparison of clinical and diagnostic features of pediatric oncology patient with or without COVID-19. Over to Dr. Saba Shahid.
Assalamu alaikum. I'm Dr. Saba Shahid and I head the pediatric department at the Indus Hospital, Karachi. I'm thankful for the ID department to invite me as a speaker for the ICON conference. I would like to share my presentation I did on COVID in patients with malignancy. I will share my slide with you. And as you can see, the title of the study was Comparison of Clinical and Diagnostic Features of Pediatric Oncology Patient with or without COVID infection. It was a retrospective chart review. I had other co-authors whom I'd like to acknowledge. Okay, so this, the background was that in February, we started getting a lot of COVID patients in February 2020. And we set up a COVID ward, which comprised both of adults and a 10-bedded pediatric ward. The ward was shared equally by malignant children and non-malignant children. So this was the time also when we decided to have our own institutional guideline based on the literature which was internationally available. As a policy, we decided that we will screen children on clinical grounds as well as on the basis of CBC initially, because it was a cost-effective intervention and almost all the children were having their CBC done. So at this time, my colleagues who were treating pediatric oncology patients, they referred to us for their patients as well. What we realized at that time was that the clinical manifestations and the CBC and hematological indices were not actually the same for oncology patients. And this was anticipated because the oncology patients, many of them have infections because of infections other than COVID, and also because of chemotherapy side effects. Also, the CBC and the neutrophil lymphocyte count and the ratios like NLR and LMR are different in these patients because they tend to have higher leukocyte counts. They tend to have neutropenias, lymphopenia. So we realized that we needed some benchmark to do disease stratification and for disease monitoring. So this was the reason we started doing this retrospective chart review. So the period was from March to June 2020. And this was the electronic records were pulled from the HMIS of our hospital and a chart review was done. We collected the final outcomes of the patient after 14 days of infection. So some of them we gathered information from on phone, while some of the children were admitted with us in the hospital. We also tried, before starting the study, decided on disease severity criteria. These criteria were based on what was done internationally. And these, if you can see that we thought we categorized the severe disease if there were 2 or more following manifestations present, which was SpO2 less than 90% in room air, presence of multi-organ dysfunction, or pediatric acute respiratory distress syndrome, presence of severe pneumonia, shock, or missing. One thing I would like to mention here is that for the PARDS ratio, there are 2 markers which can be used. It can be either SF ratio or PF ratio. PF ratio uses PaO2, which is derived from the arterial blood gas, whereas the SF ratio relies on SpO2, which is done from the pulse oximeter. It was more cost effective for us to use the SF ratio because not many children were having arterial blood gases. So the SF ratio, which is a surrogate for PF ratio, we adopted that for monitoring PARDS in our study. So I would like to share the demographic results in this slide. Total, we have 73 COVID positive patients and 75 COVID negative patients. We did not observe much difference in when it came to gender or the mean age or the type of malignancies. We saw more children having leukemia because actually this is the kind of malignancy we commonly get more as compared to solid organ tumors. Then when we saw the disease severity, asymptomatic infection were noted in 44 children, while unknown outcomes of mild infection were present in 20. Severe disease was noted in 9, out of which 5 succumbed to the disease and expired. Interestingly, the other manifestations like presence of fever, flu, malaise, and other GI upsets were quite similar in both the groups, so I did not mention them here. Which was different was presence of cardiac and pulmonary manifestations. Cardiac dysfunction was present in 4 COVID patients, whereas only 1 child in COVID negative group had a cardiac dysfunction, which was also related to the chemotherapeutic drug. ARDS was present in 6 of our COVID positive cohort, while COVID negative cohort did not have any PARDS at all. When you look at the lab investigations, we had some interesting results. When we look at the TLC or total leukocyte count, we do anticipate a higher value, and 21,000 is on the upper side of the TLC count. But what we saw was that in malignancy patients with COVID, the TLC was even higher. Then normally, if you look at this COVID negative group, this is what we do actually see in malignancy children. They tend to have leukopenia and lymphopenia. So if you see that COVID negative children here, they had absolute neutrophil count less than 500, and they also had lymphocyte count less than 2,800, which is the normal response we see in COVID patients because of chemotherapy or by the virtue of their malignancy. But the COVID positive group, they have neutrophilia and lymphocytosis when compared to their COVID negative counterpart. This was also seen in the ratios. We have to be cognizant of the fact that the neutrophil lymphocyte ratio or LMR or PLR ratio, they are all derived from the absolute values. So at the NLR ratio, if you see that the neutrophil count is directly proportionate to the LNR ratio, and the lymphocyte count is directly proportional to LMR ratio. So what we see here that the NLR ratio was low in COVID negative patients, was higher, I'm sorry. The NLR ratio was higher in COVID negative patients, but it was low in the COVID positive patient. And why did this happen? This happened because the lymphocyte count was higher, significantly higher in the COVID positive group as compared to COVID negative counterpart. This caused the ratio to be reversed. So the NLR ratio in COVID negative is actually 2.9 and 1.78 in COVID positive. Similarly, the lymphocytosis was much higher in COVID positive group, which caused an increase in LMR ratio in COVID positive group when it was compared to COVID negative. The PLR ratio was also raised, but not significantly raised. If we see this, this is what is which is represented in graphically also, that both groups, positive and negative groups, had malignancy. But if you look at the ratios and the absolute leukocyte count, then we see that the ALC, the LMR ratio, and the PLR ratio, they show the trend towards rise when we came to the COVID positive group. Whereas the NLR ratio, it declined when we moved towards the COVID positive group. So what does it actually tell us? It tells us that if we were to suspect COVID infection in a patient with oncology, looking at CBC might actually help us. If there is rise in leukocyte count, or if there's rise in lymphocyte count, then it may suggest a possible COVID infection. And if you look at the ratios, then a falling NLR ratio and a rising LMR ratio may suggest that child may actually be having COVID infection. Then the clinical features, many of the clinical features were similar, so I did not mention them here. But the interesting things which came up in the study were actually 3 things. First was chest imaging. The chest imaging findings, which comprise of either chest X-ray or HRCT or both, were actually similar in both the groups. So these children, but if you look at the ARDS, then none of the children in COVID negative group had ARDS, while the 6 children who had ARDS in COVID positive group clinically also had severe disease and severe COVID pneumonia, while their chest X-rays did not support that. So, and then if you look at the echocardiography, then the cardiac dysfunction, which was LV dysfunction or reduced ejection fraction, was more in COVID positive group. So this led us to an interesting finding that children with COVID pneumonia may actually have an initial difference of the ARDS or SF ratio, and the chest imaging findings may develop later. Then when we looked at the time which was taken to get a negative PCR, this is actually no news, because a lot of us by now know that in oncology patients, it is actually a problem that their PCR clearance is not comparable to that of normal children. We saw 19% children whose PCR cleared within after 14 days. And 7 and 3% children require 21 or 28 days to clear off their PCR report. This, by the findings of our study, we then revisited our policy, and then we started repeating PCR after initial infection, after 3 weeks of an initial infection. And then after 3 weeks, we allowed them to come to daycare to get their chemotherapy with proper precautions. And this was also noticed worldwide that the children may not be infective, but they may still have positive PCR for longer period after initial infection in oncology. So the final outcomes we saw were that 38 children got cured, 21 were advised home isolation, 9 were either referred out or left against medical advice, and 5 succumbed to the illness. So finally, I come to my last slide, which is what were the lessons we learned. The lessons we learned was that as children without malignancy, children with malignancy also tend to have milder infections. The majority are asymptomatic, and they do not require treatment. When it comes to blood cell indices, their absolute values as well as the hematological ratios differ from children without malignancy. Decreased NLR and the rising LMR ratio may suggest that child may have COVID infection and may also predict that child may have the severe disease course. Then children who have malignancy and COVID, SF ratio may be an early marker to predict that child may develop COVID pneumonia. So imaging findings may differ or may develop later, but SF ratio can suggest early presence of pneumonia among pediatric oncology patients. I thank you very much for your time and patience, and I hope that with this study, I will be able to add some insight into the pediatric COVID infections.
Thank you, Dr. Saba Shahid. It is requested to all the participants, please fill the feedback form in order to get the CME certificate. It is mandatory. So we would like we would like to ask Dr. Saba her experience about. Dr. Saba, are you there? Dr. Saba, can you hear me? Dr. Me? So Dr. Muniba, we would like to ask her experience. Dr. Muniba, can you hear me?
Yes, I can.
Ma'am, I would like to ask, what is the what have you have seen so much cases? What is the MISC in adults? How was your experience regarding this MISA in adults?
So, Miss Yes, MISC is a very tricky condition actually to pick because it is a diagnosis of exclusion. And we haven't seen much of MISC cases in adults. It's more common in pediatric population. But if you see anyone with raising inflammatory markers with multi-organ failure, roughly more than just population. But we need to keep this in mind because it is existent and we need to identify it.
Thank you,
And
Dr.
its
Muniba.
therapy is IVIG. Yeah.
Thank you, Dr. Muniba. We have Dr. Muniba and Dr. Tareem with us. Dr. Muniba and Tareem, please chairing this session. Please conclude the session and give your remarks regarding this session.
So I must say this was a very comprehensive session related to COVID-19. We started off with the acute management of COVID-19. Dr. Nosheen has very nicely presented the latest research which has been going on medications as well as on the vaccines. Then the monoclonal antibodies which are in the pipeline, hoping to see the availability of monoclonals in Pakistan as well in near future. But cost has been an issue. Professor Sohail Akhter has very nicely presented the post-COVID syndromes, which is which is actually a very challenging thing to face. People do get recover. Their hypoxia also resolves, but the fatigue, the depression, and sometimes very unusual symptoms they feel, and we need to address that too. Acute as well as the chronic management of COVID is very important. And lastly, Dr. Javed has very nicely tackled the situation of and the high importance of psychotherapy in patients with COVID-19. And we really need to have empathy for them because they are all alone, lying in a COVID unit surrounded by people in PPE. So their aggression or their agitation is a known phenomena, and we need to. Can you comment on the?
Thank you, Dr. Muniba. Would like to hear from Dr. Tahreem also, if she's here.
I think we can't
So,
hear Dr.
yeah. So we are concluding our session. Special thanks to
I
Dr.
would like,
Samreen. I
Dr.
would like,
Misbah, I would like to make a quick comment on the de-isolation thing, which is out,
yeah, in
the
short.
guidelines stating about the 5-day isolation period. It's basically adapted from CDC, and which has stated 5 days isolation period for general public, and the later 5 days the people need to keep on their mask tight on the face. So we also need to look at whether it's been practiced in our population or not, where we see a lot of mask failure in our general population. They are not following SOPs. So if we stick to this 5-day thing, the later 5 days we have to keep the mask strictly on. It's for general public. As far as healthcare workers are concerned, the CDC has a very clear policy. In the conventional settings, you need to give healthcare workers a 10-day isolation period, or 7th day with a negative antigen test. In case of contingency, when you are actually short staff, you can go for 5-day. But you see, if you are working in a COVID setup, calling healthcare workers on day 5 and asking them to work in PPE, it would be very unjust thing to do, because the fatigue and the PPE itself causes a lot of perspiration. So you have to take this on a situation basis and according to your hospital condition. I agree with Dr. Sohail that administrative workers are different, while those who are working in clinical area are different. So tackle these two in differently.
Thank you, Dr. Muniba. It was much needed because this concept was not clear. So thank you so much for clearing our concept. So we are concluding our sessions. We would like to give a special thanks to Dr. Samreen as she was a backbone for these sessions. Thank you, participating for attending our session. I would like to thank you on behalf of ICON 2022 to all speaker and participant for their valuable time. Thank you so much.